Hi, everyone, and welcome to today's webinar, COVID-19 and ERAS, Leveraging Enhanced Recovery Protocols During the Unknown. This is Mackenzie Bean, Managing Editor with Becker's, and on behalf of Becker's Healthcare, thank you all so much for joining us today. Before we begin, I'd like to walk through a few quick housekeeping instructions for our audience members. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout this session by typing them into the Q&A box that you see on your screen. Today, we'll also have a series of poll questions. You can submit the answer that best applies to you directly on your screen in the slides box. And thank you all so much in advance for your participation there. Today's session is being recorded and will be available after the event. You can use the same link used to log into today's webinar to access that recording. If at any time you don't see your slides moving or you have trouble with the audio, please try refreshing your browser. Otherwise, you can also submit any technical questions into the Q&A box, as we are also here to help. So with that, it is now my pleasure to introduce today's speakers. Joining us is Dr. Keith Biermeister, who is a colon and rectal surgeon. His practice spans a wide range of colorectal disorders, including cancer of the colon, rectum, and anus, inflammatory bowel diseases such as ulcerative colitis and Crohn's, diverticulitis, complex anal and rectal procedures, constipation, and fecal incontinence. He also performs both screening and diagnostic colonoscopies. Joining Dr. Biermeister is Rosie Squio, who is the Senior Consultant of Business and Clinical Optimization at Cardinal Health. Rosie has over 45 years of clinical experience in the perioperative setting. Since joining Cardinal Health in 1999, Rosie has held a role as a Senior Clinician for Clinical Operations, which changed to Business and Clinical Optimization of Acute Sales East in November 2020. Rosie has consulted on national and international accounts for clinical processes and practices, standardization, and change management. With her rich clinical experience, she has also presented at AORN, APIC, and many other professional organizations. Rosie has also developed and presented CEU sessions pertaining to pre-op preparedness, taking safety into your own hands, hand hygiene, double gloving, appropriate glove selection, latex allergies, including dermal reactions and skin sensitivities, heat in the OR, and the impact on surgical staff, and various perioperative activities. So today we'll hear from both Dr. Biermeister and Rosie before moving into our Q&A session. Before we begin, I would like to kick things off with just two quick polling questions on enhanced recovery for our audience members. So the first poll question asks, my facility has implemented enhanced recovery protocols, explored or is exploring implementing enhanced recovery protocols, is not interested in implementing enhanced recovery protocols, you're not sure where your facility is on this path, or other. So I'll give folks a minute to look over these responses and submit the answer that best pertains to their facilities. And again, our options are you have implemented them, you're maybe exploring it, you're not interested in implementing them, or you are not sure or have another option. We'll give just a few more seconds for folks to get their answers in and then see what the results are. All right, so it looks like nearly 42% of our audience members have implemented enhanced recovery protocols. About a quarter are exploring it or have explored it. And then almost 20% are not sure where their facility stands with this. And then we have about 14.5% in the other category. So thank you all for weighing in there. Let's jump to our next poll question, which is, how has COVID-19 impacted your enhanced recovery journey? And the options are, has it accelerated the activity and improved outcomes? delayed this activity and you're seeing declining outcomes, it hasn't had an impact, or not applicable. Maybe your facility hasn't implemented these protocols yet. So again, please feel free to select the best answer that applies to your facility, whether COVID-19 has accelerated your enhanced recovery journey, delayed some of that efforts, and you're seeing declined outcomes, it really hasn't had an effect on your enhanced recovery protocols, or this does not apply to your facility at this time. So again, we'll give folks a few more seconds to get their answers in, and thank you so much for your participation here. It's great to see where you all fall on this. Wonderful. So it looks like about 9% of folks have really seen the pandemic accelerate their enhanced recovery journey. The majority of folks said it has really delayed this activity or contributed to declining outcomes. That's pretty significant. About 21% are saying there is no impact, and then almost a third say this hasn't applied to their facilities yet. So great to get those insights. Thank you all again so much for participating in our poll questions. And with that, we are ready to kick off today's session. So Dr. Biermeister, I'll now turn the floor over to you.
Thanks, Mackenzie. Yeah, that's some great information to get started. Thank you for that introduction. Just to kind of give a little history here, so we gave one of these talks that was more of a basic overall review of enhanced recovery a few months back. We had some great participation at that point. I hope that we continue to have some great participation today. Obviously, there's some big changes in the world around us, and how this has impacted our ERAS journey obviously varies greatly from institution to institution. I don't want to take the whole time talking, because I hope that there's some questions, and I think it's more valuable you learn more and I learn more if we have more of an interactive experience. But I will give you a little bit of a review on where we are with our journey mainly, and a little background sort of on the financial impact, which should be no great surprise to anyone on the call. Moving on, just financial disclosures, you can read those, and then we'll get into the quick outline. I'll just give you a quick review on who I am. We're going to talk about defining the problem. Anytime we're talking about things, generally it's because there's a problem. We don't talk about things that are going smoothly and don't need to be addressed. We'll talk a little bit about what ERAS is, just very briefly. Again, that was mostly covered in our last webinar a few months ago. And again, a quick review of the components of ERAS. And then I want to spend most of my time on, what we've done here at Scripps, and hopefully how that can benefit you all. So just a quick background, who I am. As Mackenzie said, I'm a practicing colon and rectal surgeon, board certified in both general and colorectal surgery. I am in private practice, a small private practice, myself and one partner. We do have a fairly strong history, despite being in private practice, of administrative involvement here at our hospital with two former chiefs of staff in our practice, and my current partner is the physician's operations executive for our La Jolla campus. My background has been, for the past 6 years, I've held the role of our general surgery section chief, and starting in January will be the department chair of surgery. Obviously, I have some involvement in enhanced recovery after surgery. We'll officially say that began in 2017, but that role has probably been in place for a few years prior to that in getting the program set up and running. And then I also serve as our medical director for value analysis. I work at Scripps Health, which is a 5-hospital, not-for-profit, non-academic community system in San Diego County with roughly 1,400 beds total. It is predominantly private practice, which is a bit unique in terms of hospital setups, with about 1/3 of our physicians being employed, 2/3 private practice for now. This is the campus that I work on, which is our La Jolla campus. Of course, feel very lucky to be here. And again, I'm glad to share our results with you all today. So let's get a little bit into defining the problem. Like I said, we're not talking about this because things are going smooth and there's no issues. And I think as in the world that we're in right now, with COVID, obviously finances are key. And, you know, this was even before COVID. The financial strains on the healthcare system are undeniable. We are in a system where value directly affects reimbursement, and we cannot continue to lose money as the cost of healthcare rises without trying to make changes. We really need to strive for better outcomes. This is not something that's going to fall apart tomorrow, but unless you have your head in the sand, you can see that the trajectory is not going in a great direction, and I'll show that in some more detail later on. This seems like an obvious statement, but we need to start doing things that work and stop doing things that don't. A lot of the things that we do, especially as surgeons, and I don't know how many surgeons are on the call, but we like to do things because that's the way we've always done them, and we get in our ruts, and despite wanting to have evidence-based medicine drive our practice, sometimes we don't take a step back and look at what we're doing and reassessing how that's impacting not only our patients, which obviously should be most important, but also the systems that we work in. So we have to find value that is beneficial for both the patient and the healthcare system. To throw some numbers out there for you guys, and these can be somewhat disturbing when you hear them, but total healthcare spending in America went over $4 trillion in 2020. The impact of COVID on that is not 100% clear, but more than 30% of that, or $1.24 trillion, was spent on hospital services. When we talk about hospital costs averaged about $2,600 per day throughout the U.S., and that's a cost of a basic one-day hospital stay, with California, my state, taking the prize, not a prize that we're proud of, at $3,726. Oregon not far behind, and then places like Wyoming and Iowa, you know, doing a little better, but still, even looking at those numbers, those are pretty big numbers for a hospital stay. And then if we look at other things like complications, and specifically SSIs, the total annual cost of hospital-acquired infections, $9.8 billion, with SSI contributing the greatest percentage at 33.7%. So really what we need, COVID or no COVID, is a system that reduces length of stay, reduces complications, and not only reduces length of stay, but reduces readmissions, because we can't just get them out quicker and then have them come right back. That does nothing for us. And then we can touch briefly on the impact of COVID, that thing that's been going on here for about the past 2 years, with hospitals nationwide losing an estimated $54 billion in net income over the course of the year, and that's 2021, and that's taking into account also all the federal aid from the CARES Act. According to estimates, more than 1/3 of U.S. hospitals will maintain negative operating margins through the year's end. But there's an uncertain trajectory, certainly because of all the variants that are out there as well. We're seeing sicker patients, more high acuity inpatients, and particularly ICU patients, which we talk about those hospital stays. Those are for basic days. ICU patients, those are double, triple those costs, and we're having patients stay 30, 40 days in the ICU on ECMO, on vents, all of these. You can imagine how all of these are skyrocketing the cost. Again, high expenses rising across the board, increasing cost of labor. That's been our most recent challenge, is labor issues and burnout and staffing issues, which I'm sure every hospital across the country is experiencing, PPE and other medical devices for these higher acuity patients. So if you're more of a visual person, this kind of looks at hospital revenues pre-pandemic and how that's impacted. Again, we're back on the uptrend, but you know, this was a big hit for all systems across the country. This I thought was a very interesting slide. If we look at every recession in this country over the past 40 years, they've predominantly been, the healthcare system has predominantly been immune to the financial impacts of these recessions. Obviously, this is not the case with the current COVID-19 recession, as it is, has a more direct impact on healthcare than any of the other recessions that we've experienced previously. So what do we do? I think, as I said, we look for a system where we can reduce resource consumption and potentially avoid complications. And, you know, ERAS really fits the bill here. I'm not going to go a lot into the history, but enhanced recovery after surgery, other names that it has gone by in the past, enhanced recovery pathways, fast-track protocols, first developed in the early 2000s in Scandinavia, described in this paper by Henrik Collette, and pretty impressive results. But really, in its most basic terms, it's a multidisciplinary evidence-based approach to decrease hospital stay, reduce cost, and at the same time increase patient satisfaction. So you can see how that is not going to solve all our problems, but certainly seems to be a pretty good fit to address a lot of the current issues that I just laid out in the previous slides. And again, going back to taking a look back at ourselves, much of what we currently do is simply because we've done that. That's the way we've always done it, this idea of surgical dogma, and we really need to begin to question the old ways to make changes before it becomes too late. So if we look at just the basics of what an enhanced recovery protocol does, again, all of this was born in colorectal surgery, hence my early involvement, but really, despite it saying an accelerated recovery program for colorectal surgery patients, I might argue that we could say this is an accelerated recovery program for all surgical patients. As you can see in those bubbles, everything that's listed there can really be applied to any surgical patient. And I think this is where we've made our big strides. Is we started in colorectal, but we've expanded to multiple different service lines, 5 in total, and we continue to work on pushing for those gains in different service lines. Now it becomes a bit more of a challenge because as you get outside of the general surgery and maybe even the gynecology realm, there definitely needs to be some tweaks in the system, but we don't need to reinvent the wheel. I mean, these programs are established. There's multiple societies and established protocols that you can use as a framework for your institution, and we'll go over some of those references later on in the talk. This is a nice again, picture representation of the flow of what we look for in the components of an ERAS program. Again, these details were touched upon more in our previous webinar, but just to review, you know, we're really education and involving the patient on the front end in the pre-surgical evaluation. Carb loading is certainly a unique feature, specifically to colorectal, maybe not to some of your other service lines. Goal-directed therapy, minimally invasive surgery, early removal of drains and tubes, tubes, early enteral feeding, early ambulation, early transition to pain meds in the post-op setting, and really all this in general leads to increased patient satisfaction, decreased perioperative complications, decreased length of stay, and improved use of hospital resources, which again is really the goal here in what we're trying to achieve. So let me just take you through quickly our Scripps journey here. And again, implemented initially in 2017. Our initial protocols were vetted by a system-wide ERAS committee with each of the service lines listed here having oversight from myself and our ERAS coordinator, but each having their own surgeon champion who really drove the development of the protocols. You'll learn things along the way, and our continued involvement in each of the service lines really, besides the colorectal, obviously, where I have a much greater role, but our role is to avoid the hiccups that we've had along the way with the development of order sets, with the development of ERAS identifiers, with the auditing of the data and all of that. But really, the actual protocols are driven by those that are doing the work. In particular, the physician champions and oftentimes some mid-level providers who have particular interest in each of these service lines. So I'm going to go through quickly our data. I'll start with the oldest of our data, which is our colorectal data. The way that we audit our data is we want to just not say, hey, this is what you should do, but we want to look at those that are eligible for ERAS versus those that are ordered. That's sort of our benchmark that we go by, and we base this on CPT codes and review of the records with our data entry people. As you can see, we're not perfect, and rarely will you be perfect, especially as you start out. Any type of innovation, and I would certainly call ERAS an innovation, while no one particular component of it is very special. I think bundling these things, putting them in a package, and seeing the really significant results that you can get with them is certainly innovative, and again, any type of innovation is going to follow sort of a bell-shaped curve where early on there's going to be slower uptake, and then you're going to reach the top of the curve, and I would argue that we did and we have in our institution, but getting those late adopters, late majority to really get on board takes a lot more time. So you can see we can shoot up to 60, 70, 75%. But it pretty much lingers there, and data supports that across the system. For me, I would love an 80% participation rate. We do have some service lines, which I'll show you later on, that are worse. We do have some that are a lot better, and I can kind of touch upon those as we go through each of the service lines. Obviously the dips for COVID in the numbers, but in terms of the overall percentage, we've been pretty steady in participation. So these are our results. We look at average length of stay, SSI, and then readmissions, and that bottom graph got a little, that's not quite accurate, but that's okay. The big ones have been decrease in length of stay. When we look at our baseline data, we've basically cut our hospital length of stay in half. And, if you go back to those numbers in the early slides, that's a significant cost savings for the hospital. SSIs and how we have had an impact on those, and that's a component, certainly a component of ERAS. It is not does not define ERAS, but you can see how that's been a good trend for our colorectal patient population, and that trend continues. Readmissions, again, I think somehow that got mixed up, but the go live in March 2017. After that, there was a reasonable trend. You know, you're going to still have your spikes regardless. So moving on to our Gyne Outcomes, and you'll see that this is, and this is why I like to look at participation and not just the final numbers, because this is explainable. The Gyne service at our hospital is much larger numbers. They're much more spread out in private offices, and it's much harder to really get them to buy in and participate in this, and you can see this is on us. There is a significant room for improvement and increased participation, which will directly impact the final numbers. And we can see those here. Despite that, not bad. You know, you're not going to make huge gains when you start out at 1.8 to 2 days as your average length of stay, but again, we have pretty consistently cut that in half. This is for hysterectomies mainly. Our SSIs are down, again, with a few spikes here and there. Overall, those SSI rates are low anyway. And readmissions, again, it's not that we're just getting them out quicker. They're doing better, and the patients are not coming back. Gyne Onc, again, more, I would say, a service line more in tune with colorectal than gynecology. In these big ovarian debulking procedures, they have been pretty good in terms of their participation. In fact, in some ways better than we have in colorectal. Again, you see the dips from COVID in Q2 2020, but they seem to have recovered reasonably well. Again, cutting that length of stay in half, maybe not as significant when we're going from 2 to 1, but still that makes a difference. Cutting our SSIs down, if you look at the more historical SSI rates, a little higher, again, with these big open debulking surgeries, and cutting readmissions down significantly. Bariatrics, our second newest kid on the block at Scripps. Again, participation was very poor in the beginning, but as the message was spread, except for that Q2 2020, we've really worked on communication and getting the word out, and the results do show that as well. Again, a pretty reasonable length of stay to start with, so we're making small impacts there, but any little bit helps. SSIs have gone down significantly, which again is going to help. And one of the main goals that they had and the bariatric surgeons were seeing were a lot of readmissions, and I think we've made some significant strides there as well. The newest kid on the block is our cardiac ERAS program, and this was something that was more of a challenge, certainly a lot more moving parts than we had with any of our other previous programs. Fortunately, I think we've gotten it together. We started in October of 2020. You know, not the greatest time to start, but you can see that the participation here has been unbelievable because this is driven by the mid-level providers that basically provide all of the preoperative care. So you need to talk to the right people to get the participation going, and this is, you know, this is unbelievable with our only blip here in May of this year, where we actually had a cyber incident at Scripps that shut down our electronic medical record for the entire month of May. So that was just another challenge that we needed on top of COVID. If we look at our numbers, again, average length of stay, total length of stay, not overly impressive in terms of the gains, but I think what we've done here and has not been completely teased out, as this is relatively new data, is that we've decreased our ICU length of stay, which again is going to have huge impacts on cost savings. SSIs, again, we're starting with a very small n, so it's going to look like big ups and downs, but it's really not a huge difference. I think readmissions, significant impact there. So if we look ultimately at what this has done for our system, and this is something that was just presented to our Board of Trustees less than 2 days ago. You can see in a time where financial impact is of utmost importance, our cost savings have been pretty significant, and I think that this is translatable across many systems. This is not something that's necessarily unique to Scripps. How you do it may be unique, but establishing a program and getting numbers like this, I don't think are something that is unachievable. So just some take-home points. We've all gotten really good at what we do, and specifically from a surgery standpoint, but we can't just focus on what happens in the operating room. We need to look at what happens before, we need to look at what happens after, and we need to start questioning the way that we've always done things, because the trajectory is not looking good, and then you add COVID onto that, and it's just another hit for the system. I think with the introduction of some relatively simple, again, and this is the key, evidence-based practices, we can begin to change that trajectory. It has the added benefit of fostering an interdisciplinary collaboration and culture, which we didn't really touch upon, but these are all multidisciplinary approaches where we work with other service lines, anesthesia, nursing, administration, and especially when we're struggling now with staffing issues, and creating that culture is valuable. We can decrease hospital stay by improving care organization and decreasing morbidity. We certainly can reduce cost and improve the value of surgical care for our patients, and all of this adds undeniable value to health systems, especially in our post-COVID or hopefully post-COVID world. So these are some references. Again, I would love to speak with anyone, and we will have some time for questions here at the end, but also feel free to go to these society web pages, specifically the ERAS Society, either ERAS Society or ERAS USA Society, have very clear publications of these protocols that you can use as a guide. You cannot probably translate them word for word, as you need to figure out stuff that works specifically in your system, but don't reinvent the wheel. And that is my time, and I will pass it on to Rosie for her enhanced recovery success story.
Thank you, Dr. Biermeister. Hello, I'd like to share a success story about an ERAS kitting program, and it's also known as, or referred to, the pre-op bundle solution. So we were called, the practice manager from the colorectal surgeon's office had Googled ERAS kitting programs. At this time, the hospital purchasing department was ordering components for the physician office staff to store and then assemble for patients undergoing colorectal surgery. The purchasing department was ordering nutritional shakes, high-carb drinks, CHG wipes, spirometers, and also the patient belonging bags. The office staff kept their supplies in closets and, as needed, would place 15 protein shakes, 2 high-carb drinks, 6 packages of CHG wipes, and a spirometer in a patient belonging bag. And we all know that those patient belonging bags cannot hold all those cans of shakes. The bags often tore and were very cumbersome, making it difficult for the patient to handle, It took time for the staff to put these components together, and staff often had to check inventory status. Upon the Google search, the practice manager found that Cardinal Health had an ERAS kitting program. The manager contacted their purchasing department for contact information and then was able to speak with the Cardinal Health representative and team. The Cardinal Health rep then scheduled a call with the office practice team and their clinicians to discuss the ERAS kitting program and how we could help to streamline the process. The surgeon had put together a list of all the components that were required for the kit. The hospital purchasing department was not aware of what the ERAS kitting program entailed and did voice concern that the Cardinal rep was just trying to sell some new products. So to educate the materials management team, the physician office clinicians and manager set up a call to educate the purchasing staff on the need for the ERAS program and the benefits and cost savings it provides for patients and the hospital. The office practice team did select a roller tote with hospital logo, which would contain all the components for this custom ERAS kit. And I just put the slide up to show you what is in the bundle, the pre-op bundle solution, which we call the ERAS kit. The purchasing department was getting all the information and pricing to begin the ordering process so that the custom ERAS kits could be produced. So the key to this facility adapting the ERAS program was decrease length of stay for the patients, a decrease in the surgical site infections and post-op complications, and there was also an increase in patient satisfaction scores. I'm going to go ahead and turn it back over to you, Mackenzie.
Wonderful. Well, Rosie, thank you so much for sharing that success story, Dr. Biermeister. Thank you also for sharing some of your experience and work with ERAS at Scripps. It's been a great presentation, and we have already had lots of insightful questions come in from our audience members. So let's jump into the Q&A portion now. If you have any other questions for Rosie or Dr. Biermeister, please feel free to submit those now by typing them into the Q&A chat box that you see on your webinar console. Let's get started with the first question, which is more of a technical question about the data piece. How did you determine the eligible versus ordered data, and by which order set was utilized?
So I touched upon this real quickly. So we just based it on CPT codes. So we have a grouping of CPT codes that we feel are eligible for ERAS across the board. So, you know, when we talk about colectomy, we pull all the colectomy codes. We eliminate things like ileostomy reversal and, you know, those things that, you know, can skew the data one way or the other, and try and give ourselves the most honest assessment of the situation. And then based on pulling those CPT codes, we can see we have a standardized ERAS order set with what I'll call an ERAS identifier in them, and it probably depends on your electronic medical record system. This was a bit of a challenge for us early on in how we would identify these patients throughout their hospital stay. We were quite archaic in 2017 in that we were predominantly on paper charting, but then transitioned over to, it was a big transition to an electronic medical record, and it took us quite some time to work with our IT people and build in some ERAS identifiers that followed the patients throughout their hospital stay and allowed us to audit that. So we basically can pull initially based on CPT codes and then see based on the ERAS identifier, which is in the ERAS order sets, who did or did not order those, and that's how we determine our eligibility.
Very helpful to know. Thank you for clarifying that. We have another question how do you define readmissions? Are ED visits and observation statuses included?
So that's a great question. I think a lot of systems can fudge their readmissions by, we certainly do have an overnight, what we call a CDA, where it's not an official admission. I can't say with certainty. Readmissions are defined, I guess the short answer, readmissions are defined as readmissions to the hospital. So if we do have someone that comes in and just does stay in the CDA, that observation area in the emergency department overnight, I would guess. Now, granted, I'm not the one that actively pulls all the data, but I would guess that those patients probably are not included. But I would also guess that that's not a large number of patients that we're talking about. I guess it depends on the service line you're talking about. I always knee-jerk refer back to colorectal because that's my world. I don't think that there's a lot of cardiac patients that are coming in and being parked in overnight observation, and we're somehow fudging the data because of that. Probably the same with bariatric patients, maybe some of the gynecology patients, or potentially some of the colorectal patients might fall in that category, but I really don't think it is a huge number. But it's certainly a good question and something to be aware of in terms of your readmissions.
Absolutely. Thank you, the audience member who asked it, and Dr. Meister for elaborating on that. We have another question here about the data piece, and it is, how do you obtain your data? Is it manual or automated?
Well, we've gone through the spectrum of manual data extraction, as I said early on, and that was our journey. We were very archaic in our data collection, in that it was pulled from a paper chart, but we have now gone through with a new electronic medical record to purely electronic extraction, and that's not as easy as it sounds. These systems are very powerful and certainly are set up for a lot of data extraction, but identifying the patients and these issues is not always the easiest thing. So we have gone sort of through the whole spectrum, worked very closely with our IT people to identify these patients, and now it becomes more of an automated real-time assessment of the issues, which I think there's a lot more value in that, whereas, before we were looking quarterly, at best monthly, and you're always sort of behind in your assessment, whereas when you can look at it real-time through your EHR, I think it's a more valuable process. Now, there are specific systems that can track your ERAS data. We have chosen to build our own tracking, and those can be available through some of the societies that will specifically focus on audit, and they can have teams come in and build that audit ability for you in a separate system. The downside is that does not really talk to your electronic medical record, so it takes another FTE to input that data, so it's almost more manual despite it looking fancy.
That makes sense. Thank you for elaborating on that as well. We have a couple of interesting questions here more about the change management side of this. This audience member writes, do you have any advice for navigating the lack of nursing resources while implementing a new protocol? I found resistance due to staffing shortages.
Well, that's a great question, right? Especially and very relevant right now. I think, I had mentioned throughout my talk that we're all struggling with staffing shortages. Fortunately, we have really established our protocols, and ERAS has become second nature to most of our nursing staff. But I can certainly understand how now, in particular, trying to start up a protocol would be quite a challenge, because to put anything more on your staff's plate right now is going to certainly be met with resistance. What I found was very effective when we first started our protocols is just communicating, talking with the staff, telling them why they're seeing these changes, and then allowing them to see the impact that they have on patients. So it's not just the words that you say. You do need to give it some time and allow them to understand the impact that these types of protocols can have on patients. And once they see that, that is better than any words that you can use. But certainly they need to understand why these changes are happening. And then once they understand that, they need to see the changes happen. And that's really when you get buy-in.
Absolutely. That why piece in patient education is so critical. We have another related question that I want to pose as well, which is, what would you say is the most common objection from providers to implementing ERAS protocols that you've heard or seen, and what's the best response to that, assuming maybe similar to what you've said on the, education and really seeing the change?
Yeah, so that's another great question, because you undoubtedly will run into resistance with these changes. Surgeons are creatures of habit, and we do not like change. I think that data really is your most important tool to use, because I can promise you that every surgeon thinks that their data is the best, but the reality is that is rarely true. When I talked about our colorectal data and our eligibility data, I truly believe that what you need to focus on is the people that will buy in initially. There is always going to be people that just, no matter what you say, no matter what you show them, they will not change. And it depends on your system. As I said, we're in a predominantly private practice system, so we can make suggestions. We can say what we believe best practices are, but we cannot make someone practice the way that we want them or we know is the best practice. If you are in a certain system where you write the check of your doctors, then you can very, very much tell them what to do, and that probably is a lot easier. That's not the world that I live in, but I think really focusing on those early adopters, early majority, the ones that may be a little hesitant, maybe need to see a little literature. You need to show them not what's happening at the hospital across the country, but what's happening at your hospital. So leverage the data that you get from those early adopters and show that, and then you're going to get another surge of these sort of late majority that just needed to see a little bit more information, and that should get you to that 80-85% threshold. That last 15%, just forget about them. They will never come along no matter what you do, but you need to focus on the changes that you can make and in the people that you can change.
Absolutely great advice. So thank you, Dr. Biermeister. We have a similar question, but looking from the patient perspective. This audience member says, we have had a lot of pushback for diabetic patients using the carb-loading drink. Any suggestions there?
That's another great question. It depends on where you fall on the data, and we've had some issues with this as well. Our sort of party line is that in type 2 diabetics who are well controlled, we leave it up to the prescribing physician, given that the data is not really great. But if you actually understand the physiology of what you're doing with carb loading, and that you're not just giving patients a load of sugar, you're actually decreasing their insulin resistance and increasing their glycogen stores, which causes less fluctuations in sugar and finger sticks than it would otherwise happen. having said that, for type 1s, we do not provide them with carb loading, but we still hold to modern fasting guidelines and encourage clear liquid diet up to 2 hours prior to their scheduled procedure. So it just depends on your beliefs as a physician, your understanding of the physiology of how carb loading works. I am a huge proponent of carb loading in well-controlled type 2 diabetics. You probably want to get a hemoglobin A1C to prove that they are well-controlled. You want to make sure you get a finger stick in the pre-op area to make sure that you have not caused their sugar to skyrocket to 400, but I can honestly say that I've never seen that. I've never, ever seen that, and I think the benefits far outweigh any risk that is there for these patients, despite what some endocrinologists might say.
Fantastic. Thanks for sharing your thoughts there again. We've had a lot of questions come in asking about how much does the kit cost and who is paying for it. Rosie, can you touch on that one?
Yes, the hospital actually picks up the cost for the ERAS kits, the ones that are custom made from Cardinal Health. And the kits are variable in price based on the components that are in the pack, based on how many nutritional drinks are in there, how many packages of CHG wipes there are, the spirometer. So it varies from hospital to hospital based on what the doctor has asked to have put in the kit. But anyone that is interested can work with your local Cardinal sales rep on building out a kit and what you want to put inside it, similar to how we do other pack programs like for the operating room.
Great, helpful information. Thank you, Rosie.
You're welcome.
Another question. Thank you. Dr. Biermeister, another question for you. Does your hospital have plans to use ERAS in the orthopedic branch of surgery, both pre- and post-operatively?
Yeah, actually, that is our next service line. Well, it is on the list of 3 of our next service lines. We have urology coming up. We also have, we really want to get a program up and running in our spine service line, and then our total hip and total joint. And again, my plan with these is to leverage what has already been done elsewhere to get a strong physician champion in each of those service lines who is supportive and knowledgeable about these things that are out there, because unless you're living under a rock, I mean, these things are happening. I mean, and that they're happening in whatever type of surgical service you're operating under. So it's getting that buy-in. But yes, I think, and that will be, if we talk about cost and impacts of cost, I mean, there's so much variability in the orthopedic service lines, and really getting them to protocolize those things and leverage those benefits, I think, will be hugely impactful. And I know that there are systems across the country who have already made huge impacts with that. So yes, the short answer is yes. That's my homework for now, is to start working on those service lines.
Wonderful. And speaking of service lines, we have another audience member who is asking for more information on ERAS for pediatrics. Is there anything you can share about that?
So actually, there is. We do not have a very big pediatric service here at our hospital in terms of pediatric surgical services, but if that person were to look on the ERAS USA Society web page, I know the yearly meeting was either this week or next week, and I unfortunately could not make it, but I know one of the big agenda items was pediatric ERAS. So if those papers are not already published in terms of the protocols, they certainly will. So if you just go to the ERAS USA Society website and look at the agenda for the meeting, you can even see who is giving the talk on pediatric ERAS, and I'm sure my experience has been that people are always very open and willing to share what they've done because they see how beneficial this is for whatever patients they may be treating, and we've had great success in reaching out to other institutions. When we established our cardiac protocol, we were flying blind, and we reached out to a couple institutions, and they were instrumental in really helping us establish our protocols and coming back. And sometimes it's good to have a like for like conversation. In other words, a cardiac surgeon does not want to listen to a colorectal surgeon on establishing protocols in their world. So having that come from another cardiac surgeon who has proven data is really much more impactful than it is coming from me.
Absolutely. Thank you for highlighting those resources. We have another question here about the use of heated IV fluids. This audience member is asking, do you use them before and after surgery? If so, how much of a benefit have you seen? And if you don't use heated fluids, can you explain why not?
We do not, as my understanding. Fluids in general are a sort of a hot topic. I do defer to my anesthesia colleagues in terms of that. The most controversy that I have heard has been in the realm of goal-directed fluid therapy as opposed to heated fluid. I'm not aware of that data or what the benefits may be. If someone has some information, again, I learn from these things as much as I give out information. So that's one that I've not heard of, but I'm always having an open mind for ways to improve patient care. So if there's some good data behind that, I would love to hear about it. But yeah, I mean, really our party line at this point is judicious use of IV fluid. When we first started our protocols, it was always, it was hanging a bag of saline, opening it wide and letting it run in, and then when that ran out, hanging another bag and letting that run. And we've been really clear with our anesthesia colleagues that whatever method you use to monitor fluids, it's a judicious use of IV fluids, especially in bowel surgery and the impacts that can have on postoperative complications, postoperative ileus, anastomotic leak, those types of things. But again, if there's great data somewhere on warm, heated IV fluid, I'm not aware of it, but I'm always open to suggestions.
Wonderful. Well, thank you again for weighing in, Dr. Biermeister. We have time for a few more questions. The first is, what is the role of nurses in ERAS pathways? Are they involved with pre-surgery counseling or any post-surgery follow-up?
So, that depends on, your setup of your office and of your system. For me personally, and again, I'm speaking in particular with our colorectal protocol, I do all the preoperative education. I do all the postoperative follow-up. That's just the way my world works. But as I pointed out in our cardiac protocol, they have a very significant involvement in their mid-level providers who do provide all the preoperative education and all the postoperative follow-up. And you can see that when you take the physicians out of the mix, you can see how the protocol eligibility skyrockets. So nurses are an unbelievably important part of these protocols from start to finish. pre-op, post-op, is a little bit more variable, but their participation in the hospital is undeniable and is absolutely necessary. Unfortunately, some of our process because of COVID has changed, where we had a very significant involvement in our pre-surgical evaluation nursing staff, providing a lot of the ERAS education information and just sort of basic guidelines, but that has all been stopped because of COVID, and we're doing a lot of things remotely, but they still will make phone calls to the patient to make sure that they've gotten all their supplies and they have everything that they need, and they're very well versed in answering any questions that the patients may have around those products.
Wonderful. Well, I think your answer, Dr. Grimmeister, cues us up nicely for the last question of today, which is, for hospitals that did see delays in implementing protocols due to the pandemic, what recommendations would you have on reengaging?
I think that, they need to really see that the overall picture here, this is going to be a huge cost savings for the hospitals. I think you need to involve your administration, especially with staffing shortages and straining on that end of things right now, to really push these protocols. It seems like one more headache that no one wants to do, but if you really understand the benefits and you've seen the benefits before, I have a hard time believing that engagement will be that much more difficult now as things begin to, we'll say, normalize, or hopefully normalize again. I don't know if that's a great answer. It's a tough one when it depends on where you were in your ERAS journey. If you were sort of just ramping things up and then you got hit with COVID, that's a tougher sell, right? Because people don't really appreciate the benefits that are out there. But I promise you, with the data that I shared, and again, this is not unique. There's hundreds to thousands of hospital systems probably across the country who I would hope have similar stories that you can share. It's not always as meaningful if it's not your own story, but I still think that it carries some weight.
Absolutely, I agree. And Dr. Grimmeister and Rosie, I just want to thank you both so much again for sharing such great thoughts, having such an important discussion with us today. And thank you as well to Cardinal Health for sponsoring today's webinar. To learn more about the content that was presented today, please check out the resources section on your webinar console and be sure to fill out the post-webinar survey. Thank you all so much for joining us today, and we hope you have a wonderful rest of your afternoon.